So good evening, everybody. Thank you so much for joining us for the Bleeding Disorders Foundation of North Carolina's Health Insurance Finding the Right Fit session. We're really excited tonight to have with us Michelle Rice. Michelle is an experienced executive in healthcare policy and advocacy. She's worked across many areas of healthcare, including payer relations, federal and state policy, and pharmacy concerns. Most recently, Michelle served as the Chief External Affairs Officer with the National Hemophilia Foundation, responsible for NHF's public policy strategy and agenda and building key external partnerships. As the mother of two sons with severe hemophilia, Michelle has spent over 32 years advocating and leading change in various roles. She has held several board positions throughout her career, including the Indiana Comprehensive Health Insurance Association, the Foundation for Complex Healthcare Solutions, and community health charities. In addressing healthcare challenges in rare disease, Michelle has led transformational change in the patient advocacy space, facilitating dialogue and collaboration between payers and providers. While at NHF, she created the Comprehensive Care Sustainability Collaboration, which is now being replicated by other national patient organizations. We are very, very fortunate to have Michelle here tonight to help educate us related to insurance. Thank you.
So I can just share my screen, right? Because
yes, you should be able to.
Let me make sure that I get the right screen on.
Yeah.
I have three screens, and so
choosing the right one, and then sometimes it'll show presenter mode, so we'll let you know.
Right, there you go. Can you see it okay?
Not yet. Press share at the bottom.
Okay, I thought I did. Weird. I thought I already, oh, duh. I'm sorry.
It's okay.
All right.
Perfect.
Now you can see. So first of all, long-winded, introduction. The most important thing to remember is I'm a mom of two kids with severe hemophilia. I have mild hemophilia myself. My oldest son also had epilepsy, Hep C. So no one dreams about growing up to be an insurance specialist. But in our community, it's kind of forced on you. So this is just a lot of knowledge that I have learned by living it, also by having the being fortunate enough to serve on the Indiana Comprehensive Health Insurance Association really gave me much more insight into how insurance works. And it gave me the opportunity to really start talking to a lot of payers. So I'm just going to share. Some of this is going to probably be, some of this you may feel is pretty basic, but there's just me again. Just to let you know, I now am, as Charlene mentioned, I worked for NHF. I now started my own consulting company, Michelle Rice and Associates, because I'm really creative with names. But really it was, my intent was to be able to focus really primarily on what's happening in the health insurance space. And I believe that in the invite, Charlene talked about the fact that we are not going to spend a lot of time talking about Medicaid or Medicare tonight, but more about commercial insurance. And that is where some of my strongest concerns are for patients over the next few years. So again, some of these slides will be really basic, but I just want to make sure that everybody has a really good understanding of what the terms are we're using mean. So honestly, what is health insurance? It's a type of insurance that covers a portion of a policyholder's medical and pharmacy costs. How much and what is covered by the insurer really does depend on the details of the policy itself, as well as local, state, and federal regulations. So, typically policyholders' costs such as co-pays, deductibles, and co-insurance while it's outlined in the plan, those are often impacted by the rules. Like I said, whether it's at the state level or at the federal level. You're going to hear the term managed care a lot in what I talk about. And, you know, hemophilia in the past, actually a lot of rare diseases in the past, were excluded from managed care, partially because they were so expensive. And originally it was because many patients used to receive their coverage through Medicare or Medicaid who used managed care. What happened was over the years and leading into the Affordable Care Act, we knew that managed care entities were really going to start playing a bigger role in the insurance space, both in commercial insurance, whether it be through your employer or through the marketplace. And we also knew that more Medicaid programs were really learning enough about rare disease that they felt comfortable being able to move it into managed care. So just kind of wanted to say managed care plans is kind of a healthcare delivery system that's organized to manage cost, utilization, and quality. And there's lots of different types of managed care plans, you know, that fall under kind of that designation. For example, an HMO, an EPO, POS, a PPO. I'm going to explain what those are here in a second, but just wanted you to know that much like the government, insurance companies love acronyms. So I want to make sure you know what those are. So one thing I will say is that it's really, really important that you know what your options are, and then that you understand what type of plan or policy you need so that you can make the right choice for your family. And again, it's really important to understand what you can get through these plans as you're making your decisions. So healthcare coverage basically comes in three buckets. There's private, which is employer-based, marketplace health plans, and individual plans. You know, individual plans is something we never thought we would ever be able to get because, of course, back in the day, if you went to a health plan and said, you know, filled out your application and wrote that you had hemophilia, it took about 20 minutes for them to come back and deny you because they had the right to underwrite people out of plans. But now, let's say you're somebody who, you know, is looking at a marketplace plan. You don't have it through your employer. You're looking at a marketplace plan, but you don't really qualify for subsidies. Sometimes you can go out into the individual market and maybe find something that is more in line with what your family needs. So that's what we mean by individual plans. Public healthcare is Medicaid and Medicare. Also, it's like your CHIP programs through Medicaid that are for children, but their parents may make too much money to qualify for Medicaid, but they meet other requirements. CHIP is a program where you can, depending on that income, you may be able to buy into that plan. And we always say others, and others typically is our veterans healthcare. That may be VA plans, it may be CHAMPS, it may be the other thing that typically falls into there is tribal coverage. A lot of Indian reservations have their own type of coverage that's recognized. And so that's kind of other. One thing I'm very excited to not kind of show here is we used to say other also included uninsured. As a community, the bleeding disorders community has done a really good job over the years of making sure that our patients have some coverage. Even before the Affordable Care Act, I think we did a pretty good job of making sure that people were covered in some way, shape, or form. So I'm excited to say our numbers are very low compared to maybe others in the US population. But why is it important to know what kind of plan you have? It's because not all plans are created equal. You know, I'm going to give you some, you know, definitions and some, you know, insight into these different plans. I remember when my kids were diagnosed, the thing to have was an HMO, and everybody had HMOs, health maintenance organizations. Now they have what they call EPOs. Let me tell you, a health maintenance organization is going to be one of the cheapest plans you can get, the least expensive. And I will say this, if your doctors are in network and your drugs are covered and you don't travel a lot, an HMO may actually be a really good plan for you and cost effective. They tend to have smaller networks. They do have fixed copays, and they typically have some lower premiums. Two of the biggest, you know, negatives to an HMO is you're going to be required to have a primary care provider, or as we used to say, you're going to have a gatekeeper. That person, you don't get to get, you know, other services like specialists, or even sometimes your, if you have to have CT scans, things like that, everything goes through your primary care physician. So it can take longer sometimes to get things done. You always have to get referrals. And it seems like a lot of times when you need a specialist, you don't know you need the specialist till you're in an urgent situation, and now you have to go get a referral. And what I always like to say to people is, look, that first time you go and get something done without a referral, technically they could deny you, but most insurance companies are going to forgive you the first time. They're not going to forgive you after the first time, right? They're going to say, okay, we told you you need referrals, so we're going to do this time, but no more. And then they mean that, no more. The other thing about HMOs, and the reason I say it's important to think about your lifestyle when you're choosing a health plan too. When I was at NHF, I was on the road 2 weeks out of every month. The chances of me getting sick outside of my network area were pretty high. And, or having an accident or doing something were pretty high. And with an HMO, you typically do not have any out-of-network benefits unless they determine it's an emergency. And notice I said they determine it's an emergency. It's not up to you. And, you know, I always used to think about this when I was traveling, because a lot of times you'll see where they talk about loss of life or limb. Well, to me, there's a lot of other things that could be an emergency that are not that severe. For example, if you're somebody who's traveling and you're getting on a plane and you have an ear infection, very, very painful, very, very difficult, you know? So again, those are some of the downsides. But again, if you're somebody who you pretty much are live and work where you work where you live, and you don't travel much, and if your doctors are in network, it could be a really good option for you. Now, an EPO, an exclusive provider organization, is similar to an HMO, but the difference is typically you don't have to have a primary care physician. You don't have to have referrals to see specialists. Their networks are often larger than those for HMOs. I believe they also have, fixed copays and lower premiums. They are like a step above an HMO. They also don't do out of network services. But if you travel, a lot of these EPOs, when I say they have larger networks, they may have a national network. So for example, at NHF, we had United Healthcare and we had an EPO. And if we didn't live in the region where our plan was based, we had the ability to use their national network. So UHC has plans in almost every single state and every single area. So again, that was a big plus, and you didn't need referrals. But again, if you happen to be somewhere and they don't have a national network, or you're in a place where there's not a provider that's in that national network and you need services, again, they're not going to pay unless they deem it to be an emergency. So, some other private plan options, a point of service plan, again, like an HMO, a point of service plan, or POS, requires you to obtain a referral from your primary care physician before seeing a specialist. The difference is that a point of service plan typically offers out-of-network benefits. You'll have to pay higher cost shares for out-of-network providers, and the premiums are slightly higher than an HMO. So if I'm looking at cost, so far I'm going to say HMO is the lowest, EPO is next, point of service is next. Then you get to preferred provider organizations. And this is a type of health plan that includes both in-network, which they call preferred providers, and out-of-network coverage. Again, though, co-pays for in-network providers are typically lower than those for out-of-network providers. Referrals aren't needed for specialists, but the premiums are higher. So what that means is, it's you're paying for the extra freedom you have to be able to go out of network. And again, I always say to people, when you're thinking about your costs for your healthcare, a lot of times we think about that thing that comes out of our check, that premium, right? Need to think more about all of your costs, your copays, your deductibles, your maximum out of pocket. And then the other thing is, it's so easy for us, I think, as people with chronic illness, to think about the chronic illness, not to think about all the other things that we have, and unfortunately, fortunately, my hemophilia doesn't give me a lot of problems, but my cholesterol, my high blood pressure, all those things do. So it's really important when you're thinking about your coverage and what your costs are, to really think about those out-of-pocket costs too, because sometimes those don't seem as big of a deal to us. I go to the pharmacy and I pay $25. It's easy to write a $25 check, but when you're writing that check and it's for your factor that first time, and you have this big deductible or this out-of-pocket, that's kind of what sticks in our minds when we're looking at our insurance. But it's really important to think about all those other things and think about everybody else in the family and what their issues are too, because they come with costs. And then, the last one I'm going to talk about is a high deductible health plan. Now, this is not something that typically I or other advocates would necessarily suggest for somebody who has a chronic illness, especially one that is very front loaded with costs. And what I mean is, factor's so expensive, you're going to hit that deductible all at once. And then you're going to have to pay that in order to be able to have your plan start kicking in to pay anything else. And so they do have low premiums, but they have, again, higher immediate out-of-pocket costs. And a lot of employers will pair a high deductible health plan with a health savings account. And again, the idea behind this is, it's great, because then if you don't spend your all the money that you have in your health savings or in your high deductible health plan or your health savings account, you can roll it over into retirement. Again, somebody with hemophilia isn't going to have money to roll over from their HSA with a high deductible health plan, because it's going to your factor cost up front. And again, it's great because you may be able to deposit pre-tax dollars. Sometimes your employer will help fund part of it. And the thing about a high deductible health plan is it can be an HMO, it can be a POS, it can be a PPO, an EPO. I mean, it can be any of the health plans. It just has that high deductible attached to it so that they can lower premiums. Another thing to remember is if you are somebody who's taking that risk and going with, maybe if you're a mild, you might think about taking that risk. I don't know. But to remember that some services, and this is true for your other health plans too, some services like mammograms, colonoscopies, annual well visits, vaccinations can be covered free of charge, even if you haven't met your deductible. They won't have a copay. I will tell you that we always say the devil's in the details. When I think of mammograms or colonoscopies, where do you usually go to get that? You usually go to an outpatient surgery center. You may not have a copay or a deductible for that mammogram or the colonoscopy. Where they get you, though, is you may have a copay for the facility. So just so you know, you may actually have that fee as if your fee is, when I go to an outpatient facility, I have to pay $50. You're probably going to have to pay that $50, even if it's a colonoscopy or a mammogram, because that's the facility charge, not the service charge. So just to think about that. The other thing is, where do you go to obtain private insurance? A lot of us think of job-based or employer-sponsored insurance, which is great. Insurance plans offered to you by your employer. The other is the health insurance marketplace, healthcare.gov. Now, typically, if you have insurance through your employer, I would say to you that it's typically going to be less expensive than you going onto the marketplace because of a couple of things. One is, if you have access to health insurance and you choose to go to the marketplace, a lot of times that disqualifies you from getting a subsidy. So the fees in the marketplace, while people will look at that and say, oh, it's so expensive for insurance. I was talking to somebody the other day. It was like, my insurance on the marketplace is $500. I said, actually, I know you only paid $100 at your employer, but let me tell you, that's because your employer was paying a very large amount for you to get that. So actually $500 is really not that bad. But it's a shock to the system, right? And, so just to understand that typically if you have job-based insurance, I'm going to say most times it's going to be more affordable. And in a lot of ways, it's probably going to be better coverage than what you might get on the marketplace. But there's also, like I said, the private health insurance market. Sometimes you can contact health insurers directly or through an insurance broker, to obtain quotes. One thing I will tell you is when you're going into the private market, I'm going to say buyer beware. Because there are a lot of plans that, do you have Farm Bureau insurance? Let me ask this. Do you have Farm Bureau insurance in North Carolina? It's a big association, right? They offer these health plans. And I just went through this with a family member. And these plans look amazing. The cost is very reasonable. The coverage looks great. And I was like, something's not right. The other thing I'm going to tell you is always read the small print on any of your insurance documents. Right at the very bottom, they have a note that says, this is not ACA compliant insurance. Other times they will say it's not an insurance plan, it's a health program. So once I started looking into it, I found, because it's not an ACA compliant plan, it was a little better than a skinny plan, but not a whole lot better. They were able to put in they were able to put in pre-existing condition clauses. So for example, you couldn't, if you were pregnant when you came into the plan, they wouldn't cover that. You actually couldn't get pregnant until after you've been on the plan for 18 months. There was also, basically I looked at it and I was like, every single one of the medications I take would be considered a pre-existing condition. So for 12 months, I'm going to pay for a plan that I can't use. unless I get a cold or unless I get, bronchitis or something like that, I could probably go and get paid for that. Or if I had an ER visit. But if they're related to any of the conditions I had, it was not covered for that first 12 months. So you really have to look for those kinds of things. Association plans can be great if you're somebody who's pretty healthy. The other thing that I mentioned, the word skinny plan or catastrophic plan, what I found is that a lot of like hotels, service industry, hotels, fast food restaurants, they'll say they have insurance, but what it really is catastrophic coverage. Again, I had a friend that encountered this and was working for a very large hotel group. Her son was shot and was in ICU. And on the second day, they came in and said, well, you have 2 more days of coverage. And then there's no more coverage. And she'd been with this hospital or with this hotel group for 10 years. So she'd been paying in for this insurance, thinking it was insurance. It was catastrophic coverage. So you can find yourself with a lot of cost. So it's really, really important. I always say, if it sounds too good to be true, especially when it comes to insurance, it's too good to be true. If you're not sure, and sometimes a broker can lead you the wrong direction. And I don't want to say that they're not doing it maliciously. I have found that some of them just don't understand it either. If there's someone who hasn't had to use a lot of insurance benefits themselves, they don't look for the kinds of things that I'm going to tell you to look for, right? They look at it and go, yeah, this is great coverage. Hey, there's only a $250 deductible and a maximum out of pocket of $4,000. This is wonderful. And look at the premiums, only $300 a month. Yes, but if you have to use it, it's probably going to cost you a lot more. So just make sure that you are looking at that. If you have questions, we are so lucky in this community. We have our HTC social workers and nurses who are incredibly knowledgeable about health insurance. We have, you have NHF, you have HFA, you have your local chapter. There are a lot of places people can go. And many of those places have my phone number too. So they can call me and sometimes do to help in those situations. But, a lot of people don't have that. They don't have that expertise for somebody to help them. So please use it. The other thing that you may not think about is, and this is a really underutilized resource, the manufacturer of your medications, of your clotting factors, have an insurance, have like a patient assistance portal. And we think of those for like their free factor programs, their free trial programs. When I don't have insurance, they actually, many of them have the ability to help you look at your insurance plan, understand what, the limitations are. Many of them even have the ability to help HTCs with getting, the prior auths through and those kinds of things. So definitely consider those options. It's almost almost an embarrassment of riches as far as, people who can help us. So I think that's important for you to know. Then I just put this in there because I knew Charlene was going to record this and could put it up. This is just kind of gives you one place that you can look at that says, okay, where are they different? I didn't list copays, co-insurance, and deductibles because they all have them, right? But this tells you kind of, do they have out-of-network benefits? Do they have a provider? What does their provider network look like, whether it's wide or narrow? Just some of the things that I think were big questions for you to be able to take a look at. Here's the one that I am really, really want to make sure you understand. For those of you who get your insurance through your employer, it is very important that you understand if that is a fully insured health plan or a self-funded health plan. And let me explain to you the difference here. And I found this great chart, which I loved. But a fully insured plan, the employer will pay monthly premiums to an insurance carrier, and that insurance carrier will decide those premiums really in a lot of ways by looking at the employer's kind of history, right? They're going to say, okay, you have this many employees, you have this many people in the past who have chosen family plans versus individual plans. Here's what you want for your deductibles and stuff to be. So we're going to say that, they have actuaries in-house who will kind of determine what's the potential risk for us with this kind of big population. They've got 5,000 employees, 2,000 of them are on family plans, 2,000 maybe individuals. And the others may be a mix of either employee and spouse or employee and children. And then what they'll do is they'll figure it out and say, okay, this is what we're going to charge you for each one of those categories. And we take the risk. We're going to assume that we've charged you enough that the premiums cover the cost of the medical expenses, because there will be people in those companies that don't use much, of their health insurance benefits. Others will be heavy users. But the idea is they're playing the odds that they think they're going to be covered. So let's say that in a fully insured plan, the employer pays $1 million a year in premiums. If the health costs, if the health benefits if the usage ends up at 1.5 million, that insurance company is on the hook for that extra 500,000. They can't go back to the employer and ask for more money. They're on the hook for that. In a self-funded plan, which may look very similar to you when you get your insurance card, a self-funded plan, the difference is the employer hires one of these companies, an Anthem, a Blue Cross, and says, we want to use your network and we want you to administer claims for us, but we will write the check. So in that scenario, I'm paying the insurance company to just do administrative work for me. But whether it's every month, whether it's every quarter, that insurance company comes back to me and says, okay, here's the claims, for this quarter. The employer writes that check. So in that scenario, let's say I'm, as an employer, I'm guesstimating that I'm going to save $1 million, and I'm going to put it into a fund that I'm going to say, this is going to be what I use to pay my employees' healthcare costs. If it goes over that 1 million, that employer now has to add more money to that pot, right? They are on the hook. They are the ones taking the risk. They are the ones that are playing the odds. And the advantage to them is, hey, if I don't pay out $1 million, I have carryover money. I've saved money, right? So again, this is the risk that they take. We have seen an increase in the number of self-insured plans in the market. Typically, it used to be, you'd say, oh, if a health plan's if an employer has over 500 employees, many times you'll find those are the ones that are more likely to be self-insured. However, we saw that number starting to drop down for a while. I know of health plans that had 150 people, and they chose to go, or employers that had 150 people, they chose to be self-insured. You get much below that range, and it's awfully risky for an employer to do a self-insured plan. I just met with somebody this past week that was like, I'm going to do this. I have these businesses and I have 20 employees. I want to take care of them. The way we have insurance now is going away. I'm just going to become self-insured. And I'm like, oh, no, you're not. Because I'm going to tell you how much that is for you. Because I knew that they had health concerns. So that is a risk, not necessarily for you, but it is for the employer. What is a risk for you, or the reason you need to know if it is self-insured, is self-insured plans do not have to cover all of the 10 essential health benefits that were created in the Affordable Care Act. And that includes prescriptions, that includes ambulatory services, child services, preventive services. They don't have to cover all those things. Historically, have they? Yes, but that is changing. And this is why, for me, this is why I wanted to focus on this personally in my career moving forward, because this is the area where I worry most about our community. Right now, I can tell you about 60% of our community is covered through commercial plans, whether that is a employer plan or a marketplace plan or an individual plan. And of those, somewhere around 50 to 60% are on self-insured plans. The other thing to recognize is that your card may look the same. It may still say United Healthcare, or it may say, Blue Cross Blue Shield. What you can often find on your card is it may say this, or Blue Cross Blue Shield acts as the administrator of this plan. That tells you it's probably self-insured. They're letting you know that they are not the ones responsible for all of the expense. Sometimes that's not clearly indicated on there, but it is a question you should ask during your open enrollment. The other thing is, which can be good or bad, is that employers have more control and freedom over their plan designs. The reason I say it can be good is sometimes, let's say they're using a third-party administrator and they choose to use their formulary list. And maybe clotting factor's not on the formulary list, or maybe it's on the formulary list at a really high tier. And you explained, to your employer what that means to you. Sometimes the employer could say, okay, I'm going to change that. I'm going to put that on a different tier, or I'm going to make that formulary because I realize that my employees need that medication and right now they can't access it. The reason it can be negative is what I will get to coming up here. So I'm going to go back to, how do you know which plan is right for me? There was a study done and they said that most employees spend less than an hour in choosing, in completing their benefit enrollment every year. Now think about this. We know how much insurance costs. We've all dealt with it. We know what our factor costs can be. We know what our, other expenses may be. Many of you, I'm sure, could say this. I'll go to 5 different stores to find a sale on something that I want to buy. And it may only save me, and I may be talking $300, and I can get it here for $250, but I'm going to go and I'm going to look for that sale, right? I'm going to look for the best price on a car. I'm going to look for insurance for people with chronic health conditions is one of the most important decisions you will make every single year. And the problem is, in most cases, once you make that choice, you are in that plan for a year. The only exception to that I'm aware of is sometimes in Medicaid, if you're in a managed care plan, they may allow you at a couple different times a year to change your plan. But typically, once you're in for the year. I always look at the questions that, I tell people they should ask. I always look at the questions as kind of, what are questions that anyone who's looking at insurance should ask? And then what are the ones that are kind of bleeding disorder specific? And if you're somebody who has more than one health condition, again, you need to think about what the specific questions are for those as well. But the standard question should be, how much does it cost? And again, don't look just at the premium. Look at the premium, look at the deductibles, look at the co-pays, look at the co-insurance. And I I will tout this program from here to eternity. At NHF, we created a personal health insurance toolkit. And I will tell you, I have used that personally with my family members who are choosing Medicare plans. I amended the program and trained all of the HIV advocates that work for our state Department of Health on how to use that to work with HIV patients. You know, it is really a great tool, especially the personal stat sheet, to help you, as I said earlier, to start triggering those questions in your mind of, oh, okay, I know about Factor, but how many prescriptions am I getting every single month? Maintenance drugs. How many maintenance drugs is my spouse getting, or my kids? How many times am I taking my kids to see their pediatrician every year? That there's a cost share. What we've done is in that personal health stat sheet, it asks you questions, it lists questions that relate to benefits that all come with a cost share. So it's a way for you to kind of make this list and then really start saying, okay, how much is this plan really going to cost me? Because how much is this drug when I get it filled each month? How much is this drug? So again, look at what is my maximum out-of-pocket cost? Do I have out-of-network coverage? What are the kind of what are the rules around that out-of-network coverage, right? Do I need a referral to see a specialist? What services are covered? And by services, I mean, is it medical? Is it comprehensive pharmacy? Is it not? Because we're going to talk a little bit about how, you know, they can cover pharmacy, but not really cover pharmacy. And then, is this a fully insured or self-funded plan? And really, the reason you want to know about the self-funded plan, also, you want to know if it's a large group plan, and I'll explain that here in a second as well. But those are kind of the questions that everyone should ask when they're looking at open enrollment. But the bleeding disorder specific questions is my Factor product covered? Don't just look and see that you see one Factor product on there. I just looked at a plan today and they only had one product covered and it was only Factor 8. And I'm like, what happens for the rest of people, you know? And they offered 2 different formularies. But the formulary that was with this one was what they called an essential formulary versus the comprehensive formulary. When I looked at their comprehensive formulary, all the Factor products were on there. But of course, that wasn't what was available to this individual. It was this other program. The other thing that's important to know is once they say, is my Factor, you know, once you find out if your Factor's covered, is it covered under the medical or the pharmacy benefit? Back in the day, I would have said 90% of plans covered it under medical. Now it's probably more like 50-50, maybe even 60-40, as far as health plans covering it under pharmacy benefit. And there's a couple of reasons they do that. When it's under the medical benefit, a lot of times it's really hard to track it. You know, what's the usage? How much? Because, you know, you see this, you know, month supply come out and it's kind of in with a lot of other things, or it's coming from, you know, it's in connection with a hospital stay and it's kind of in with a bunch of other things. It's hard to figure out exactly how much is being used and how much is being charged. Under the pharmacy benefit, a health plan can limit where you're going to get the product and which they can tier them, right? So which product are you going to have access to? They can also choose to put some as non-formulary. I will say that just because something is non-formulary does not mean you cannot get it. You know, always pursue access. Always pursue access. Just know that it may take you longer if it's non-formulary. So, but it's important to understand the other thing about medical and pharmacy benefit is that affects your out-of-pocket. How much you're going to have to pay at what time. Is your HTC in network? If you're somebody who doesn't go to an HTC, if you go to a local hematologist, is my doctor in network? What services or benefits require prior authorization? Factor used to be once a year. The beginning of the year, the HTC would send in a note that says, here's the person's diagnosis, here's the product I'm using. That is because there were very few products. They were all around the same cost. And honestly, this community had gone through HIV. They were going through Hep C, and quite honestly, insurance companies didn't want to touch that, right? They didn't want to cause more issues. Now we have, I think with Factor 8, we have almost 25 products. And the thing with Factor is every time a product comes out, it tends to be more expensive. And ironically, then all of the other products tend to go up in cost too. So insurance companies are saying, okay, we need to figure out a way to control these costs. We want to make sure that there's a reason that somebody has to use this higher cost drug or this higher cost service. So now what's happening sometimes with Factor, it's once a quarter you have to have it. Sometimes it's, just twice a year. I've even seen a couple of companies who do it every month, which is awful. And we've been able to try to talk some of them out of that because it really creates a lot of work for them as well. It's not like my weight is going to fluctuate so much from one month to the next that I need to have a big shift in my clotting factor. And the other reasons that matters is you need to know if you need prior authorization because, like I said, they'll forgive you once. But if you don't do that, you're going to end up with a bigger out-of-pocket cost. And here's the doozy is, does the plan have an accumulator adjuster or maximizer program? The other thing that you'll hear is, do they have a cost savings program? That's how they're describing this phenomenon that we like to refer to in the industry as the alternative funding model. And when I said to you that self-insured plans do not have to cover all of the essential health benefits, this is my big concern, is we are seeing more of these large self-insured employer groups. First of all, they were using the accumulator adjuster. Now they're using the maximizer, and they're starting to use this alternative funding model. And what that is you'll get a notice, when it's time to, when you do your open enrollment, they may send you a notice that says, hey, just so you know, these drugs are no longer covered. However, we've entered into this prescription savings program that can help you get your product for free or greatly reduced cost. What these programs are, actually, they tell the employers, we can help make sure, nothing for your employee changes. They get their medications the same as they always did. But we can either work with an international pharmacy to get lower costs, or we can work with grant programs or pharmaceutical company programs. My experience is they aren't working with international pharmacies. Number one, the federal government says you cannot import biologics. So they couldn't do that anyway. There are some arrangements with Canada, but outside of that, they can't do that. What they're doing actually is they say to the employer, we will, in 72 hours, give us 72 hours when you have a patient that needs one of these medications. By the way, exclude all of these medications from your formulary list. When the patient comes to you and needs one of these medications, you refer them over to us. We will sign them up. We will find out what their needs are. And in 72 hours, we will find a program for them. What they actually do is, in some cases, they have you sign a power of attorney. We've seen some that were like And basically it's giving them the authority to talk to anyone, any pharmacy, any pharmaceutical company, to try to get you your medication. So what they'll do is that, let's say you're using one particular Factor brand. If they go to that company and you don't qualify for their assistance program, which, by the way, the assistance program I'm talking about is the program that these companies set up for those who truly are uninsured. They'll see if you qualify for that. If you don't, then they'll go to manufacturer number 2, manufacturer number 3. And then what they say to the employer is, these products are all the same. It doesn't matter. We got them on this program. What they then say to the employer is, look, we're successful about 60% of the time. But if we're not successful, you can always make a medical exception. And we have a pharmacy that will help get you the product. Now, the key word there is you can make a medical exception. First 2 years this was out, that's what most employers did. Now, look, they're all hurting from COVID. They're targeting these people specifically because they're in, health or in job markets that were hit hard in COVID, manufacturing groups, that kind of stuff. Pretty exciting for them to say, I'm not going to cover this. That's maybe costing me $400,000 a year or $500,000 a year. I will tell you, there are lawsuits that are out there right now trying to challenge this, but this is a very big concern for us in the advocacy space. As you know, there was a bill introduced last year at the end of the year in Congress to try to do away with accumulator adjusters and accumulator maximizers in self-funded plans. Many of you, and I'm trying to remember, does North Carolina are they one that ban accumulators and maximizers? The problem is that is state law. State law applies to applies to fully insured plans. So when I said to you earlier, large group employers, some large group employers don't have to follow all of the ACA requirements, but they are often subjected to state rules and regulations. But so we had to do a federal bill in order to try to get accumulators and maximizers banned from self-funded plans. I know that NHF was still working to try to get that bill reintroduced this year. If not, I'm sure it's on the agenda for early next year as well. So again, important to ask those questions. They don't make that real obvious. It's often doesn't show up on your summary of benefits. It doesn't say we have an accumulator plan or a maximizer. And typically it shows up in the plan document. And when you look at it, it sounds like it's something really good for you. You are eligible for our prescription savings program, but the savings is for them, not for you. So it's important for you to look for that. Also, always ask for a copy of the preferred drug list and ask if they have a separate specialty drug list. Because if you get the preferred drug list and you don't see Factor on there, chances are there's either a specialty drug list that's going through pharmacy, or that may mean that it's covered under major medical. Whatever it is, you want to know that. So I did include this. I want to be able to leave time for questions, and I know I'm way past time. So this will be something you guys can look at, and it does explain how these programs work. There are a couple of links on here that you can click on that really do a great job of explaining these programs. And again, this is just me talking to you about following the roadmap to choosing a plan that's right. This is again about utilizing the personal health insurance toolkit. And here's your list of resources. And I apologize because I know I went over, but I want to be able to have people ask questions if they have questions, and I haven't looked. Looks like there might be questions in the chat.
Yes, yes, and no problem, Michelle. Are you okay if I send out
Oh, yeah.
the PowerPoint too?
Oh, absolutely.
Okay, wonderful, because then that way they can click on the links. I've already started prepping an email so I can send the insurance toolkit, which I see is in here too, but we do have some questions. I'll start with the ones in the chat real quick,
Mhm.
and then I think I started it. Okay, if your job offers a private health plan, one of the catastrophic ones that you were talking about, would that also make you eligible for the ACA subsidies? I know employer plan does, but what about the private ones?
Well, here's the deal. If you have an employer plan that doesn't meet the definition of actuarial value, and there is a formula for that.
Mhm.
And I've only been able to get somebody a special enrollment using that argument once. Just so you know.
Yeah.
Sometimes that will give you the ability to go into the marketplace and get a subsidy.
Okay.
And so again, that's something that if you really don't think your employer, in this particular case, they didn't cover factor. The patient was also diabetic. They didn't cover the some of the diabetic supplies. So this patient was having to go to the hospital, not only for their insulin, but also for their factor. And I actually was able to get the third party administrator, because it was a self-insured plan. The third party administrator went to the employer and said, "You're going to kill people. You can't do this." And they went with me to CSIO to get them a an exception, and we were able to get that person that. So yes.
Okay, great. And then someone asked and they said, I may have missed this. How do you know if your plan is fully insured or self-funded? I know you did mention about look on your card to see if there is something.
Yes, and a lot of times it will say under where you contact somebody, it'll say, United Healthcare is the administrator or handles the administration of this program. That's usually a good indicator that it's self-insured.
Mhm.
And
If you don't see that, is it pretty safe
yeah,
to assume it's not? I mean, is it a question you can ask your employer without kind of raising
oh
flags?
yes. I don't think that is I don't think asking that question in and of itself
Mhm.
is a trigger for
Okay,
an employer.
great.
So for example, on my card, it would say, says the name of the, United Healthcare. Here is your medical claims address, da 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 da, for pharmacy questions, for whatever, here it is. And then it'll say, here is your United Healthcare network. So it was clear to me that it was a fully insured plan, because it didn't say anything about administration.
Mhm. Got it.
And that's usually the trigger for that.
Okay. And then another one is, how do you find the answers to the questions to ask during open enrollment when your employer only provides the overview documents and not the full plan document?
They should be willing to provide you a link to the health plan online. And a lot of times you can actually go in that way and look for it there. Sometimes they'll have, if they have a broker that's helping with open enrollment, like they may have somebody come in from the company, whatever. A lot of times that's somebody that you can ask those questions. Sometimes it's difficult because when you call the health plan, they go, well, you have to be a member before we can tell you, well, I'm trying to decide if I'm going to be a member. Sometimes that's something your HR person can help you with. You can just say, I want clarification of some of these benefits. Who can I call? How can I get to either somebody at the health plan, or who is a contact for me, or do you have a link for me to go to? And I will say this, no matter when you're talking to a health plan, always ask and write it down. Who am I speaking to? write down the date, write down what your question was. If they tell you, like, for example, a lot of times when you ask, is my factor covered? They'll say yes, and you'll say, okay, under pharmacy or medical, and they'll go both. Well, okay, explain to me what that means. Typically what that means is inpatient, if you're inpatient, or if you're having someone like a nurse come out and assist you in giving your shots, that's maybe covered under medical. But if you're doing it yourself, so always ask, well, what about for self-infused medication? Ask that question. Again, always write down who it is. And then when they say that it's covered or not covered, say, can you point me to where that is in my plan? So that you can then pull that out. I also always ask, just for kicks and giggles, hey, would you send me that in writing? Because every once in a while they actually do. And then you have that to, back up if they try to say that that was incorrect information.
That's great. Thank you. And then another comment, but also I think something that you can help is my concern with asking too many questions up front for self-funded plan is that you might be showing your hand and your child's spouse may go over the projected cost for each employee.
Yeah, I don't think asking them if they're self-funded is in and of itself going to be a problem, because I think there's so much information out there. It's not an uncommon question for people to ask now, because there is so much information out there, that's telling people about the differences between these types of plans. I've been doing some work the last few years, and just recently met with several insurers, and I also met with a broker who works with some of the really large self-insured employer plans. And he encourages them to, tell people if it's self-insured or fully insured. And most insurance companies, even if they're fully insured, they have what's called stop loss coverage. So self-insured employers typically have this too. If it's going to be over $250,000, like let's say that's what they tell themselves in their mind, each person's going to cost me about $250,000. A lot of times they will hire what's called a stop loss carrier. They pay so much per member for this stop loss carrier. And what happens is once they hit that threshold that's been agreed upon, then the stop loss carrier pays any of those other costs.
Yeah, I think the question, Erin, correct me if I'm wrong, but is more like, you have a self-insured plan, but now you're asking those questions about, trying to, you don't want them to identify you through those questions that you're the one that's costing them so much money. I know I've had people who, not asking very specific, but have said like, oh, I just tell them I love to, like I'm a geek. I like to know everything about everything. Like, but if you're asking specific bleeding disorder related stuff,
that I would say you're going to ask the insurer. So look, if you've got these 3 plans, and in that summary of healthcare benefits for each one of those plans, it should tell you what those cost shares are. Okay. And they should give you a link to your preferred drug list. They should give you a link to your provider network. So, and when you look at the plan, Erin, you'll see how it explains to you how to go through and do that. And when you look at the toolkit, it explains to you how to do that. So you're not asking them that question.
No, I'm actually, my question, Michelle, I don't mean to interrupt you, but it was more like when you're getting a new job, right? Mm-hmm. And they're telling you, we're making you this job offer, here's all our stuff. Are you guys self-insured? Are you fully insured? Like, people are like, why? Why do they want to know that? You know what I mean? Without tipping your hand. I had an experience. My son was born when my husband was working for a company that was self-insured. Well, all hell broke loose because we were blindsided with the hemophilia. So everybody knew, but he would sit in meetings, he's a controller, and he would sit there and they'd be like, okay, we have 6 employees that are like over the numbers. We know we've got so-and-so and so-and-so who are going to chemo. Like, even though they can't identify them, they can sort of figure it out kind of thing. And he used to sit there like this, so it's always had like a little pit in my stomach when it comes to that. So that's, it's esoteric and it's out there. So you don't even have to like go into it, but it's just food for thought.
I think the difference is now there is the Genetic Non-Discrimination Act. Yes, we all know, and I'm sure you know this as a lawyer, there's ways people can get around that. There's so many at-will states.
Mhm.
What I will say is, again, I think it is, especially if you're going to a large employer, you know, some of them may tell you that they're self-insured, but I think there's so much more information out there about health insurance that it's now not a real triggering question the way it was before. I mean, my plan was self-insured. My husband's plan was self-insured when our son was born, and we again found out very traumatic way, lots of ICU. We maxed out on our lifetime cap at age 4. So everybody knew who we were, right? Because it was 150 employees and they were like a big family. So everybody knew when our kid was sick. So I do agree they are not supposed to know who the people are. But yes, can they try to figure it out? Yes. The other thing to remember is if you're in a group, you're going to a plan that's got 500 employees or 5,000 employees or 1,000 employees, you are a blip on the radar screen.
Mm.
They really are not going to necessarily even, a lot of them have told us they don't even find out they don't even find out about high cost claims until second quarter. By that point, you're already in there, you're already, so again, I don't know that I think that would trigger a question, but I hear a lot of people ask a lot of really detailed questions about their insurance. And so I just think that employers right now know that this is top of mind for people.
Okay. Thank you.
Mm-hmm.
And then I'm going to go out of order real quick, Reed. I will get to your question, but I just wanted to ask, I know in North Carolina, many of us are familiar with accumulator adjuster program or adjustment programs because we had to do a lot of education with the legislation and stuff. And if anyone watching this recording needs information, again, it's in the PowerPoint, but we also have some webinars that we had saved as well. But, and I know you touched on the alternative funding model, which is, or funding, that's obviously another concern that we have going on right now in the community. But I don't remember, and I'm tired, so I could be forgetting. Can you give a brief explanation of what is the maximizers, the copay maximizers? I know it was a couple slides ago.
Yeah. And I will tell you, one of those videos that I gave you is actually one that Colette did in connection with our Comprehensive Care Sustainability Collaborative program. And she has some payers in there with her and some other folks, and they go over kind of all of these.
Oh, great. Good.
But what I will say is the difference with the maximizer is with the accumulator adjuster, they just look at what your current copay and deductible is. What the maximizer does is, let's say you have a copay card that's $12,000. Your copay per month is now going to become $1,000 a month. So what's interesting is when you look at the drugs, they don't have that fixed deductible anymore, right? Because it could be different for different drugs. And part of that is because maybe the copay card is different. But what it does is it takes that full value of that copay card and divides it out over the year. The concept is that, and that will count, right, towards your deductible. And, and the thing is that they're saying, well, then nobody gets hit with a really large charge all at once. So in theory, it was good when they first came out with it. They've now done a little, some kind of wacky stuff with it. That the problem is we were all used to, if it really counts towards your out-of-pocket and deductible, you hit that in January.
Mm-hmm.
Okay, so now that hits your pharmacy deductible, your medical deductible, everything. So now what happens is if it's going out over the year, you may end up having other copays. Like, and maybe they're not horrible, right? It's the $20 at your doctor. It's the $10 at the pharmacy, but it's an adjustment that we are not used to. And
Mhm.
actually you really are coming out of pocket a little bit more.
Yeah.
So I, originally they were all using the accumulator because it was easy. And then of course the language came out saying, states came out and said, no, you can't use it. So then they started to go to the maximizer. And now they're going to the alternative funding, and they're even starting to emerge that too. So, but Colette does a really good job of explaining that. And I will tell you another thing about this community, Colette is recognized as the international or the national expert on these 3 programs.
Mhm.
Other advocacy groups call her. So I always said, great, that's what you want to geek out on, that's yours.
Yep.
But yes, she is the resource to go to
It's
on that.
fantastic.
And I saw Reed's question about going out of the country.
Yes.
And I just had this question this weekend. One thing to know is if you are getting coverage through your employer, some of them do have coverage for when you go out of the country. And it may be a separate kind of thing. You have a separate number you have to call, a separate, but you can ask that question of your employer. If I'm going out of the country, what is the coverage? Sometimes you have the ability to buy, travel insurance that may have some medical with it, but it's never going to be enough to cover what you probably need. But there are, that's something that you should follow up with your employer. And a lot of people don't even know that they have that on their plan. It happened to me. I was at a world meeting in Australia and was sick as a dog. And finally, the 3rd day, I was like, I don't care how much it costs going to the doctor. And then I found out that, hey, we had coverage on our plan. So, but it's a separate kind of special number that you call to get that information. So hopefully that helps you, Reed.
And any other questions? Again, I know we ran over time. I know some folks had to go, but again, we're recording this, so we'll send it out. But
Oh, Reed, you're on a Medicare plan and a supplemental plan. Now, I would ask if there's, I would ask Marla if she knows if there's coverage for Medicare. But your supplemental plan, though, that would be a good question to ask them. If you are out of the country, is there any coverage? Marla's kind of my Medicare, guru. I'm learning more of that now, but she would be one I would ask if she knows if Medicare provides any coverage when you're out of the country. But some of those other plans may very well. The supplements may, or if you're on an Advantage plan, I don't know. It depends because it would be considered an emergency in many cases. So.
And I do know you can buy insurance for when you go overseas. I don't know if that's across the board, no matter where you go, but I had read about that from some travel thing I was reading one time, and they said, know what your insurance is going to cover and all this stuff. And they choose to buy insurance before they go overseas in certain places because of a health condition the woman in the blog had. But
yep. And the best thing is obviously when you're going overseas to take your factor with you, because that you may not have access to, depending on where you're at.
Yeah. Any other questions or comments?
And again, Charlene, if you get comments after, you know how to reach me. You can send me questions. I'll send you back answers, The biggest thing is just, I am really concerned about the sustainability of employer-sponsored insurance right now. And so it's really important to kind of understand what you're getting through your employer.
Yeah, definitely. Well, wonderful. I'm going to